Safety and efficacy of sofosbuvir daclizivir in the treatment of COVID-19. I am Dr. Mustafa Yakut, and these are my disclosures. This figure shows the similarity between the hepatitis C virus and the SARS novel coronavirus 2. Both viruses are enveloped single positive stranded RNA viruses, and both share properties and use considerably similar viral genome replication cycle and mechanisms. Structural modeling studies confirm the high homology and conservation and support the concept that SARS-CoV-2 RNA-dependent RNA polymerase is much more similar to that from hepatitis C virus than the one from negative sense RNA viruses such as influenza and Ebola. Thus, it was anticipated that the important targets for therapy for novel coronavirus 2, as a successful example in hepatitis C virus, should include the RNA-dependent RNA polymerase and the replication complex. And this slide shows the similarity between the life cycle of both hepatitis C virus and the coronavirus in CoV-2. This slide shows the life cycle of the SARS-CoV-2, starting from the virus entry by binding of the spike protein to the receptor, the angiotensin converting enzyme 2 receptor on the host cell, and then translation in the cytoplasm, and this will release the polypeptide, which will be acted upon by chymotrypsin-like protease and other proteases to release the important RNA-dependent RNA polymerase, which complete the replication cycle. Sofosbuvir, daclizivir, lenacapavir, ravidasvir are examples of already available direct-acting antiviral drugs that act through inhibition of target viral enzymes, including RNA-dependent RNA polymerase of hepatitis C virus by competing with the natural ribonucleotides. It was suggested that by the same mechanism, such drugs might be able to also inhibit coronavirus, including the nCoV-2, the non-structural protein 12, which is the SARS-CoV-2 RNA-dependent RNA polymerase, and both the non-structural protein 7 and non-structural protein 8, which are cofactors. And this figure depicts the high binding affinity of sofosbuvir to the polymerase enzyme by the docking experiment. And also this study by Mondal et al. Shows that sofosbuvir exhibits the highest binding affinity to the non-structural protein 12 and to non-structural protein 7 and 8 and RNA of the coronavirus 2. While this study from Cynthia et al. Shows that daclizivir exhibited very high affinity to the RNA-dependent RNA model by the Autodesk Vena, and this shows the binding sites. Another study by Muhammad Sadawi et al. Showed that the direct-acting antiviral drug ravidasvir and daclizivir, in addition to the bioflavonoid hesperidine, shows the highest binding affinity to the neuropilin 1, which is one of the SARS-CoV-2 receptors. In vitro studies showed that sofosbuvir and daclizivir inhibited SARS-CoV-2 replication in type 2 pneumocytes, the CALO3 cell line, and prevented virus-induced neuronal apoptosis and the release of cytokine storm-related inflammatory mediators by monocytes. Daclatasvir also targeted SARS-CoV-2 chymotrypsin-like protease enzyme and other secondary RNA structures in the SARS-CoV-2 genome. Sofosbuvir terminated RNA was shown to be displaying substantial resistance to excision by SARS-CoV-2 exonuclease-based proofreader, and this is an important study published in Nature. Another study showed here the predicted daclatasvir plasma concentration for multiple 60 and 330 milligram doses. The plasma concentration here, as we see, is above the effective concentration 50 and above the effective concentration even 90 for those doses of 330 milligram. Study design and setting. This is a parallel two-arm randomized open-label active controlled clinical study conducted in an outpatient setting in an isolation hospital in Cairo. Inclusion criteria. Subjects or their legal representatives have signed the informed consent form. Subjects are aged from 18 to 75 years old. Laboratory confirmed COVID-19 by PCR assay and symptomatic COVID-19 with clinical severity at baseline ranging from mild, moderate, or severe. Mild here is defined as clinical symptoms with no picture of pneumonia in CT scan plus positive coronavirus in throat or nasal swab by PCR. Moderate fever and respiratory symptoms and pneumonia visible in CT scan. Severe but not critical, meeting any of the following criteria: respiratory distress, respiratory rate more than 30 times per minute, finger oxygen saturation below 94% in rest state, PaO2 over the FiO2 below 400 millimeter mercury, but above 200 millimeter mercury in order to judge the patient as capable of treatment in the ward and not necessitating to be included in the ICU. Exclusion criteria: pneumonia due to other etiology, clinically severe COVID-19 cases requiring invasive ventilation at screening, patients who have severe concomitant illness that affects survival, pregnant or lactating females, hypersensitivity or contraindication to any of the drugs used in the study, patients with cirrhosis or abnormal liver enzymes with more than 3 times the upper limit of normal, and renal dysfunction with glomerular filtration rate below 30 milliliter per minute per 1.73 meter square. Patients were randomized into 2 arms. Arm number 1, experimental, were 44 patients who received the standard of care therapy as per the Egyptian Ministry of Health protocol, together with a daily dose of 1 sofosbuvir 400 mg tablet combined with 1 daclatasvir 600 mg tablets. Both were generics by Farco. on day 1 through day 10. Arm 2, the control group, 45 patients who received only the standard of care therapy according to the Ministry of Health protocol, and this included the hydroxychloroquine, azithromycin, vitamin C, zinc supplement, acetaminophen, and the cough mixtures as needed, and treatment escalation with anticoagulation or parenteral antibiotics or oxygen therapy according to the case progress in the world. Primary endpoints: proportion of clinical recovery, composite within 21 days, composite sustained more than 24 hours, normalization of fever below 37.3, and normalization of respiratory rate below 25 per minute, and oxygen saturation 94% or above on room air, and at least 2 points improvement in ordinal scale by the World Health Organization. Time to clinical recovery, composite from initiation of study treatment until the resolution of symptoms, sustained for at least 24 hours. And mean change in clinical status using ordinal scale from day 3 through day 21. And the ordinal scale consists of from 1 to 9 to 8. 1 means died patient or death. 2, hospitalized on invasive ventilation or ECMO. 3, hospitalized on non-invasive ventilation or high flow rate oxygen. 4, hospitalized with oxygen supplement. 5, hospitalized non-requiring oxygen but need medical care. 6, hospitalized not requiring supplemental oxygen or ongoing medical care. 7, not hospitalized with limitation on activity and or requiring home oxygen. 8, not hospitalized with normal activity. Secondary endpoints were time to or proportion of virus negativity by PCR of nasal or pharyngeal swab sustained for at least 48 hours, proportion of patients who needed escalation to mechanical ventilation and or died during the hospital stay, time frame 21 days, proportion of participants with treatment emergent serious adverse events leading to study drug discontinuation. Statistical plan. Group sample size of 44 in group 1 and 44 in group 2 achieve 81% power to detect a difference between the group proportion of 0.24. The statistic used is Z-test for proportions with bootstrapping. The significant level of this test was targeted at 0.05. A Kaplan-Meier curve was used to report the probability of progression over time to clinical recovery, and was compared between groups using a Cox proportional hazard model with adjustment for baseline disease severity indicators. Results. Between June and September 2020, 89 patients had been included in the study and all were randomized and received their assigned medications. 44 patients were treated with sofosbuvir/daclitazivir add-on to the standard of care, the experimental group, and 45 were given the standard of care therapy alone, the control group. Baseline characteristics were balanced between groups as illustrated in this table. Age, male, percent, severity, mild, moderate, severe, comorbidity, vital signs at baseline, laboratory finding on admission, and these are, as we see here, there is no difference between the groups. The proportion of cumulative clinical recovery in the experimental group at day 21 was numerically greater than the control group. 91% with confidence interval from 78.8 to 96.4% versus the control group, which showed 77.8% with confidence intervals 63.7 to 87.5%. The relative risk here was 1.17 with confidence interval 0.97 to 1.4, which is not significant, but the hazard ratio for time to clinical recovery adjusted for baseline severity estimated by Cox regression model was statistically significant with hazard ratio 1.59 with confidence interval from 1.01 to 2.5. The experimental group also showed trends to greater numerical improvement in all studied clinical efficacy endpoints, including the 8-point ordinal scale score, the severity of lung lesions score by CT, and the case fatality rate, which was less than half, 4.5% in the experimental group versus 11.1% in the control group. All these effects, though, did not reach statistical significance at the study sample size, but being all concordant with the significant hazard ratio, they supported the study concept. Here is the 8-point ordinal scale, which is concordant higher numerical mean scores in the experimental group than the control group, with adjustment for baseline severity indicators, but this did not reach statistical significance in the intention to treat analysis. And this shows the experimental group showing tendency to better improvement in lung lesions with more steep reduction in the mean severity score numerically, though the difference was not statistically significant at the study sample size, but also it is concordant with all the efficacy markers in this study, which support the concept of the study. The incidence of sustained viral negativity confirmed at day 91 end of follow-up showed no statistically significant difference between the group in intention to treat analysis by two-sided exact test with bootstrapping. Two patients in experimental group versus 5 in the control group suffered severe deterioration necessitating admission to intensive care unit and invasive mechanical ventilation, and all died in the ICU. No serious adverse events reported, only comparable mild non-serious events in both groups. Discussion. The highly variable natural course of COVID-19 with a considerable proportion of spontaneous recovery and low unpredictable incidence of fatality could make the results of observational studies to evaluate treatment difficult to interpret. Even in large-sized randomized controlled studies, it was practically difficult to detect a statistically significant reduction in mortality beyond the standard of care. This may be due to the low fatality rate at the background fatality rate in both groups and the small effect size. The 3 smaller studies from Iran have been recently published, and they also showed efficacy and safety of supraverbal with or without ribavirin in the treatment of COVID-19. In conclusion, although our sample size was not large enough to have power to detect tiny effect size, yet the hazard ratio adjusted for baseline severity by Cox regression was statistically significant, 1.6. This signifies that at any time point during the study, the clinical recovery in the experimental group has about 1.6 times greater probability than the control group. This, together with the concordant trend to better mean scores of the 8 points ordinal scale, greater improvement in lung lesion scores, and lower case fatality rate in the experimental group, which was below half of the control group, though did not reach statistical significance but could add support to the potential benefit of tofosbuvir daclizumab in the treatment of COVID-19. Thank you very much.